Hello. Holy shit, wait. Cheers, wait.
Yeah. You're gonna have to.
I didn't memorize it.
I
have an audio message of import to this. Let me get back into Signal. All right. This is my friend Konstantin Davinsky. He's a libertarian, a Russian-Jewish libertarian from Pennsylvania.
The way to say cheers in Russian is na zdоровье, which means for your health or to your health.
Na zdоровья.
Can't roll my tongue.
Na zdоровья.
Na zdоровье.
Na zdоровья.
Na zdоровье.
To your health.
Thank you very much, Konstantin.
Yeah, it's kind of funny because I've watched a lot of Bald and Bankrupt. Have you ever heard or seen that YouTube channel?
Bald and Bankrupt.
Bald and so he tours a lot of the Soviet Union, or the what was the Soviet Union, and speaks fluent Russian. And it's a great. Anybody who hasn't heard of Bald and Bankrupt, check out his YouTube channel. And I'm sure I've heard Nastarovia. I'm sure he's said it before, but yeah. So now we know.
All right. Well, thanks for that, Konstantin. Thank you for being Russian and Jewish.
Yeah.
I like the fact you're Jewish.
You're checking off boxes. I mean, that's diversity right there.
Yeah.
We got the enemy and our friend. So it's the enemy of our friend is our enemy, or the, what's that? Whatever that saying goes. The enemy of my enemy is my friend.
He is the,
but
he can check a box on every hate group in America.
Yeah. And he's a libertarian. So that's the worst of all.
Right.
I think that's like FBI most wanted list. I mean, libertarians, if you, God forbid, you have a "Don't Tread on Me" snake bumper sticker.
Yeah.
Oh, you're on a watch list.
Oh, for sure.
And then you're going to add a Russian on top of that. I mean, the fact that he's a Jew may get him some leeway, but yeah. Welcome to the United States of America, yeah, where freedom is a thing of the past.
Nostrovia. All right, I have heard that before.
I'm sure. Yeah. So
at
my
Russian informants, that's where
totally separate page, we're talking healthcare today on the We Love the State podcast. Non-Russian healthcare. We're talking about U.S. healthcare.
It is not Russian.
Not Russian. But you know what? You can never go wrong with a Russian toast, right? Unless you're beheading somebody or throwing somebody in the gulag.
Yeah. Then it would be awkward.
Just a little awkward. Yeah, like every time you say Natrovia, you're like, oh, there's that person we threw in the gulag. It's just an awkward flashback. So no problem with that today. So today we hit the pleasure of having my doctor.
Yes.
On our podcast.
Yes.
Like how cool, like how many podcasts have you listened to where I don't know if we necessarily introduced her as my doctor, but like that close. I mean, physicians are usually things that, people that we put on a pedestal and are really detached.
Yeah.
And this is anything but that.
Yeah.
Right. I mean, that's the great thing with Belen Amat is she's personable. Like you can talk to her about anything.
Yeah.
I believe she is Spanish descent, but she did grow up in Mexico. Hence the fun first name.
Yeah.
Belen. I've been calling her
Belen,
because I've been calling her Belen. Because I think we just always automatically.
So we know that you're her least favorite patient.
Oh yeah. All right. Let's a little caveat to that. I just refer to as Dr. Amat because.
Oh, okay.
And you can't go wrong with Amat. But the fact that we don't have the little asterisks over the second vowel to notify us that that is the vowel that you pronounce.
If she has a problem with you saying Belen, just be like, how do you pronounce my last name?
Yeah, that's true. Spike Cohen, ladies and gentlemen. I will. That I will live in infamy. Yeah. So the Dutch and the Spanish, crazy people with their names. Clearly, English wasn't the first language.
I'm German. My last name is Kunz, which I feel is a little too on the nose.
Yeah, but it doesn't sound German enough. It should be like Kunz.
Okay, so
Schwarzens und Kunz. Like, yeah, you just need a little bit more.
yeah, all right. That's how I'm gonna start pronouncing.
Kunz.
My name is Andy Kunz.
Kunz. Yeah.
And put a ya at the end of it.
Kunz. Yeah. Yeah.
My name is Andy Kunja.
Kunz. Yeah. Wait, that's probably more Swedish or like Alps. Yeah, Swedish. All right. Back to the podcast. So anyhow, Dr. Belen.
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 Yep. Belen.
I'm probably never going to get this right.
I'm
sorry, Dr. Mott, because I know you're listening and your mom's listening, your brother's listening. We're not doing so good on at least I'm not doing so good on the first name. Belen Amat. Anyhow, so she is a direct primary care physician, and which is very different than a primary care physician. So, and we'll definitely go into that in the podcast, what the difference is. I guarantee you, after you listen to this podcast, you're going to look up direct primary care physicians near me.
Absolutely. Yeah.
So
this sounds like a weird infomercial.
It does.
But like for sure, this is super fascinating. And I was blown away during it. Like I barely talked at all, and that's because I'm just listening to Ben.
Oh no, he was taking
Dr.
notes.
Yeah, like it's really interesting, and it's one of the things. Like I feel like you don't really care about, or you don't really think about the healthcare industry as like a wing of the government in a way, because it's the recipient of all that Medicaid and Medicare,
and they set kind of the rules.
Yeah.
So in de facto, even though we aren't paid directly by the government, I mean, granted, Medicare and Medicaid are almost 50% of healthcare reimbursements. So, but they carry a lot of weight with how they set precedents.
Yeah.
And so we're talking about a way to break out of those chains in healthcare, which, I mean, I think that aligns perfectly with our podcast, and granted, we don't get into a whole lot of, how much government regulation plays a part in healthcare, yada, yada. I mean, we definitely do touch on it. But, if you listen, after listening to this podcast, just understand that the government is kind of that underlying condition. Speaking of healthcare, it's the underlying condition of the problem.
Yeah. Yep, absolutely. I really enjoyed this interview. Dr. Amat she is a wealth of knowledge on this shit. She is a wealth of knowledge on sort of the hospital industry and like a window into the industry that you rarely ever get to see, which is like what it's like to be a doctor, working for a hospital, and there's this whole, black hole industry that just sucks you in and you can never get out.
Yeah, I don't think people generally understand everything that doctors have to do, like in their day-to-day basis. They were like, oh, you just see patients, right? But seeing patients is maybe 20% of what they do.
Yeah.
And this really, interviews like this and direct primary care in general really call that out.
Yeah.
To say, because, I mean, we talk about waste. What is value added and non-value added to the patient? What's value added to me as a patient is my conversation with my doctor and the immediacy of that conversation, the length of that conversation, the outcomes from that conversation. Like, those are all value added to me. But from a doctor's perspective, those are what they're penalized for.
Yeah.
So, I mean, there's a lot of talk, I think, about healthcare in the United States and how horrible it is, right? Wasteful. It's all about money. If we had, Medicare for all or some type of government program, things would be so much better. And people don't understand the reason why it sucks is because of government.
Yeah.
It's not, they're looking at it completely wrong. Just like, people are like, oh, well, the stock market and the financial institutions, it's all because of failure of capitalism. It's like, nah, we haven't had capitalism in
a century and a half. Like,
I mean, when it died was when we got the gold standard in 71, roughly. When it started dying.
Have you ever been to whathappened in 1971.com?
Yes, so good.
That's a terrifying website.
So good. But like 1911, when we instituted the federal income tax and the Federal Reserve, it was kind of the beginning of the end.
Yeah.
When we went off the gold standard, it was the end. And we are reaching the end of the American healthcare system as we know it.
Yeah. Yeah.
We didn't go too far into that in this podcast. But I think
we
everybody
touched on it a teeny bit.
Everybody kind of understands. I mean, the majority of people who are listening probably have never met their actual primary care physician. They've seen a PA, they've seen an NP, but to actually have an actual relationship with your doctor is non-existent unless you're stupid wealthy.
Well, it's so I mentioned in the episode that it's hospitals are basically like assembly lines now, and I feel like that was inevitable with government being involved with healthcare, because now it's about how many people can you get through the door, because you want to get as many Medicaid and Medicare people through the door as possible, because that's guaranteed.
That's who
money.
votes for you. Yeah.
And so I mean, healthcare sucks right now because of government is what I'm trying to say. And this, like the DCPs and the direct care DPC was almost there.
Yeah.
The direct primary care is like this is how to fight back,
It's almost a reverse, and I think Dr. Amat touches on this a little bit. It's going back to almost the frontier model of healthcare, where the physician was just another person in the community, and the community was on first name basis with the physician. It's kind of that Dr. Quinn, medicine woman, like, if you have a problem, you just call your doctor. Or if the problem is big enough, maybe the doctor just comes to your house. Like, that's been unheard of in America for the last 60, 70, 80 years. And it's kind of ironic that we are going back to that model. Obviously leveraging technology. We don't have to make house calls because we have video visits. I mean, we can text, we can call, we can Snapchat, we can FaceTime. But to be able to leverage all of those with your doctor, like, is unheard of these days. And I think we do touch on this a little bit, but I think it can't be stressed enough, is direct primary care is all about relationship, right? So it is about building a relationship with your doctor and building that trust, because, Dr. Amat says a few times in this interview she has patients that are inpatient because they're so sick. And so when rounding happens in the hospital and all these doctors and mid-levels and residents are telling patients, this and that and this, that, and then they leave the room and the patient's like, I have more questions now after they left than I did when they came in.
Yeah.
And they got right on their phone and they were able to text or call or FaceTime Dr. Amat and say, here's what I was just told. Help me. Because I don't know what they were talking about.
Yeah.
And for her to be able to decode Like, I mean, I know family who've been, admitted into hospitals and didn't have that. Like, how scary is that if you're being admitted into a hospital for any condition, but it's severe enough to be admitted, and have an advocate that's your primary care physician, you have a relationship with, you have trust with, and they're at your beck and call, your fingertips. Now, granted,
not just an advocate,
but not in the middle of the night. I mean, obviously, but
like not just an advocate, but an extremely well educated advocate.
Right.
A medical doctor as an advocate.
Yeah. To have that at your fingertips. Like, I know that if I was ever admitted, I mean, even, we talk about my short stay in the emergency room this last week. I had a doctor who is I consider her a friend, and I could relay what's going on. And this is somebody, I mean, I've been in the medical field for 17 years. Holy crap. I can't believe I dated myself like that. So
Ben is 62 years old.
I look great for my age. But, even with my knowledge base, to be somebody who says, this is what I think it is, what do you think? So it's almost, from my perspective, it's almost like having a doctor as a consultant right there. For those who have no knowledge in healthcare, I can only imagine what a blessing it would be to have a primary care doctor at your fingertips. So, again, not to beat a dead horse, but you will be Googling direct primary care near me after this episode.
Or we'll find you.
Or during the episode. I mean, if you have to leave and jump right into like a direct primary care near me, we get it. Totally understandable.
But do it or else.
Or else.
Yeah.
That's the state will find you.
Yeah. All right. Well, let's get some plugs out of the way. You can find We Love the State pretty much everywhere. We're on YouTube. We have a Facebook group. We are on Locals. We never made a True Social, but that's okay because True Social sucks.
That's a flash pan. But go
to WeLoveTheState.com. I actually had somebody send me a picture on Twitter wearing only a fanny pack. So I'm going to be tweeting that out for the whole entire world to see. So
and settle down, guys. It's a guy. Because I immediately I was like, oh, that's gonna be, and they're like, oh no, I saw that picture. It's a dude, and he's a good looking dude.
Yeah, from the shoulders down.
So well, I'll take your word for it. But anyhow, I mean, that's the kind of pictures we want to see here at the state.
Yeah.
So show us, feel free to continue to send us pictures of you in our merch.
Yes.
And we will gladly distribute it
everywhere.
Yeah.
So your boss can see it. So your mom can see it.
Yeah.
Yeah. So future employers can see it.
I mean, if we ever get to the point where we're big enough for a billboard, you're going to be on a billboard.
Hell yeah.
Hell yes.
Okay. So yeah, go to WeLoveTheState.com, buy some merch, take a picture of it. I want to do like a special Locals only episode where we go through all these pictures and judge everybody.
Maybe a calendar.
Ooh.
We Love the State merch calendar.
Dude, there's got to be a place we can find like custom calendars.
Oh yeah.
For dirt cheap.
Oh yeah. And we just load the pictures so send us a picture. Are we? Oh,
you're frozen there for a
frozen.
While. Let it go.
Send us pictures and send us the month that you'd like to be represented in the calendar. Maybe it's your birth month. Maybe it's just your favorite month. But send us the pics and send us the month you'd like to be, and we might be able to make that happen. In fact, I think we can make that happen.
We will make that happen.
We have the power of the state.
We can move mountains.
Or at least make them look like presidents.
All right. If you want to follow me on Twitter, you can follow me at Andy_Coons. My largest audience, however, is on TikTok. You can find me at Andy Coons, and that is Koons. Twitter is where I say all the stuff that'll get me banned off of TikTok. So, Twitter is way more fun, if you ask me. I say a lot of naughty words.
Get him on Twitter now while you can.
Mm-hmm.
He will be banned eventually.
I don't know.
Elon Musk, that's true.
Yeah.
It may be
it's
our
a free speech platform.
maybe our only hope.
Hopefully. I hopefully.
I mean, it'd be funny if like Elon Musk renames it as Skywalker.com. Like the only hope. We were talking Star Wars Legos, and so I've got sci-fi in the brain.
Hell yeah. All right. So, yeah, go and follow us everywhere. Go to WeLoveTheState.com. Get yourself a sweater. Get yourself a t-shirt. It's winter is coming. Get yourself one of these fucking hoodies. It's comfortable. It's warm. It's the only thing I'm wearing right now. I'm not wearing pants.
And I can guarantee you it's going to get you out of tickets. So speed away, just flash the state, and the officers of the state will give you a pass, and you'll be good to go.
Yeah, they go up to your window, you say, "Hey, pig." Excuse me. Officer Pig. I love the state.
I love the state. And they will be like, so do I. Carry on, citizen.
Free to go, buddy. All right, well, let's get into this interview. This is, hey. Welcome back to We Love the State. This is the State Sanctioned Podcast. We have a wonderful guest today. Her name is Dr. Belen Amat. She's a direct primary care physician. Incredibly intelligent woman, which, what do you expect? She's a fucking doctor. She is a wealth of knowledge. And yeah, I enjoyed listening to this interview. It was incredible. So anyway, thank you for tuning in. Thanks for listening. And
see you next time.
Yep. We've got a pretty amazing guest today. I'm very excited to have her. We've got Dr. Belen Amat. Did I say the last name right?
Yes.
All right.
That's the easier one to pronounce.
So tell us a little bit about yourself, Dr. Amat. What do you do? Yeah, give us a short little introduction.
So I am a primary care physician. I trained in a program called internal medicine and pediatrics. So basically I can see adults and kids. It's a little longer than family practice. We do it a little different than family practice. And I, after residency, I worked for a little bit for 2 big hospital systems in town. And then I just, for multiple reasons, did not like it. And I opened my practice 5 years ago. And my practice is under a system called direct primary care, which is basically a membership model for everybody. So a lot of people get confused between concierge and direct primary care. Concierge practices bill insurance and bill the patient on top. So it's more for like the rich and famous, I think, because their fees are usually a lot higher. You have to have really good insurance, and then you pretty much you have a very, very small panel, and people have to have insurance because it's very expensive. And direct primary care is very accessible. Usually we set up the fees to be very reasonable. It's a lot less than paying your phone bill. And then with that, you get access to directly to the doctor. So that's the kind of the magic about direct primary care, is that you get this flavor of old medicine where you used to know the doctor really well. They used to know you really well. You know your family and all, everything. You could talk about your vacation and you could talk about your kids and my kids. And it's that flavor, but then with all the technology. So we can have the best of both worlds. We can have very personal healthcare in the primary care setting, which is where we do all the preventative medicine. And then you can have all the technology to contact people. So you can use email and text and phone and video conference and all these things. One of the benefits too is I have access to wholesale medications. In Michigan, physicians are allowed to dispense medications to our patients, so I can get medications super cheap. I can beat any pharmacy, and that's also kind of a nice little perk, is you can get your medications cheaper. Labs too, so blood work. Sometimes supplies we can get a lot cheaper because I can buy wholesale price as being in medical practice, and then I just give it a cost to the patients as a benefit. So that's kind of the generic way of how it works, is the patient pays a monthly membership, and that includes all the things that I can do in the office.
How did you hear about primary or direct primary care?
So when I was drowning in the system, every time I kind of would come out for air a little bit, I would hear about direct primary care. It's one of those like things that, life puts you like, this is what you need to do. But you get sucked in, like Jaws, how the girls like trying to swim and you just get like sucked in the bottom. That's how it felt. And it would be like another year before I could catch some air. And all of a sudden it's like, now you hear more about direct primary care. So the first time I heard, there was this Dr. Bliss in Seattle, and he wrote an article. I can't remember what magazine, but he wrote an article about direct primary care. And I read it and I'm like, that can't be. There's no way. This is perfect. This is awesome. And he described it just beautiful, and it sounded just ideal. And I started trying to find information, and there wasn't a lot when I graduated 10 years ago. There wasn't a lot of information out there. There weren't many practices doing this. Once I was like 5 years into practice, I started hearing more and more about it. And in 2016, there was a conference called DPC Nuts and Bolts, and it was like the first time that conference happened. And I pretty much went to the conference in an all or nothing approach. I went to the conference and I told my husband, I'm going to go to this conference to find more, everything I need to know about this system, and either I quit medicine or that's what I'm going to do. And I got to the conference and I called him the first night, even before the conference started, just from talking to all the doctors. This was maybe 150, 200 people kind of mingling the night before the conference. I got so much information in 2 hours that I called my husband and said, I'm doing this. And as soon as I came back from that conference, I quit my sucky job, and the rest is history. Then I kind of went to the adventure of opening a practice, which is pretty fun.
What's the, is there a pretty heavy upfront cost to starting a direct primary care practice? Or, because you've got the EMR, you've got obviously all the initial equipment, or do you kind of try to grow your panel first and then?
So you have to be very careful, right? It's a business, like every business. So if you get this huge cost up front to make it look super pretty with all the bells and whistles and staff, and you get super, a lot of money up front, a lot don't make it. It, like any business, if you spend a lot of money up front before you have any customers, well, why? That's kind of dumb. So in a way, I just started with the bare minimum. And I know you remember my office was a lot smaller. I got like the less, like the rent is usually the biggest cost. So I got a rent that is super minimal with, all the things in the building are included, and all the services are included. And so I don't have to pay like electrical and all these other things separate. So my rent is really reasonable. And then I just try to look for used stuff. So my exam table right behind me, is used. It looks perfect, but it's used. My EKG machine is like from the 80s, and it's used and it works fine. I don't need like the super high tech, $10,000 EKG machine. So I started with very little on my savings. I didn't ask for money. So this is very funny, but I actually did do a business plan with the small business development center there in one of the universities here. And a guy helped me set up like a business plan and all this, so I could go to the bank and talk to a banker. And so I talked to one of the big bankers that I'm not going to say the name, but starts with an H. And the guy laughed at me. He's like, this is never going to work. You're not going to make it. This is ridiculous. Who's going to pay for this? when people have insurance, why would they come to you? And it was like a destruction of my ego. I was like, oh my God, maybe I won't make it. By then I was not working anymore. So I was like, whoops, maybe I made a mistake. But honestly, just thinking about it, I didn't need to ask for money because it was very little money up front. I had saved up, I'm a saver. I'm like a little like chipmunk, I like to save, save, save. So I just had a little cushion. It was not a lot of money. I mean, honestly, the biggest thing was the rent. All the other stuff, I mean, you already have a cell phone. I got the cheapest computer on Amazon. All my furniture is IKEA. You can do very cheap, honestly, on the the chairs. I don't know if you know this, but the chairs in my waiting room came from my dentist because she heard I was opening a practice, and you're like, "Oh, you want some chairs?" And she just gave me some chairs. I
That's
just
cool.
my neighbor actually reupholstered them for nothing, free. So if you're creative, you can do for very little. And the important part of DPC is the personal relationship. It's not the building. It's not the computer. It's not how many staff I have sitting around checking boxes on a computer, trying to get a prior auth for something. That's not important. The important thing is the relationship. What happens when you close the door between the patient and the doctor? And that's invaluable.
Yeah, it's kind of funny because we talk about bedside manner quite often with physicians, and that really puts that as the most important part instead of everything else that traditional primary care looks at. They, if anything, you're penalized for having too long of a conversation or getting along too much or like having conversations like again for transparency's sake, Dr. Amat is my primary care physician, and when I come into the office and want to sit down and talk, like I remember what it was like at a traditional direct primary or a primary care office, and the clock's ticking. The physician walks in the door, and they know that they're on a 10-minute timer, and it's they can try to hide it, and there are a lot of really good
It's
primary care
impossible.
physicians, but
It's
yeah, it
impossible.
really is to really, it's literally like, why are you here, what are your symptoms? I mean, it's a checklist, and then they're out to see the next patient.
It's
And
what can I diagnose so I can bill, and what can I prescribe so I can bill higher, and how many boxes can I click so I can bill higher so we get paid, and next, next, next. And it's horrible as a physician. Doctors don't complain, and I think that's why there's so much. They call it like burnout. It's not burnout. It's called moral injury. Physicians are hating their job because you become a computer input technician. You're not even using your brain anymore. The computer reminds you what patients need, and then all you need is like
your
follow the
license.
protocols. So any trained monkey can do it, right? I mean, you don't need a physician. You need somebody who went to school for 12 years and has all this like intense residency training with very sick patients to click on boxes. Any trained monkey can do it. And you can see it now that pretty much anybody can practice medicine. You go online and do a 3-year program, not even that 2-year program. You don't even have to see patients to get a title of some sort. And then you end up in an urgent care seeing patients and just prescribing whatever is the next fashion, right? And so physicians hate it because you come into work early to try to catch, try to like not fall behind. By the time you start your day, you're already a half an hour behind because it takes a half an hour to room a patient or two. By the time you go in the room, you're already a half an hour behind, and you can hear the other rooms being roomed. So you if you don't like you go fast, you're gonna end up 2 hours behind, and people are gonna get mad at you, and then they're gonna hate you, and they're gonna complain to the administration, and then you get dinged on your monies, and so it becomes this like vicious circle of torture. And then
Well,
you have this training to help people, right? So I get in the room and talk to you, and you say, okay, I have this issue. I feel down, and I don't know what I'm going to do with my life. And I'm like, I can hear the next patient there, right? So I don't have time to talk to you. So what I'm going to do is I'm going to refer you to 20 other different people who are going to give you an appointment in 8 months, and your issue was never addressed, but we clicked on all these like quality boxes because we took your blood pressure, which is useless, right? It makes no sense. It's all discombobulated. It is not a system that is based on treating a patient. It's a system based on billing
It sounds,
and
I
making
mean,
money.
the way you describe it, it just sounds like an assembly line, at any factory,
Mhm.
And so how much, I mean, at an assembly line, how much care and individual attention is each part getting? None. I mean, just the bare minimum just to get them by to the next phase.
Well, and a lot of the stuff in medicine is being made into protocols. So you have to follow the whatever protocol is the standard of care, and you stop using your brain, because why would you need to use your brain if it tells you if patient has A or B or C, then do the, it just tells you what to do. Patients don't really follow protocols. They don't read the book and show up with the symptoms that might indicate a serious illness. It doesn't, people don't show up like the textbook. And that's why being a doctor is more an art than science, because you get trained in all this medicine, but you really learn by seeing patients. So that's why residency is so vital, that you see more and more patients and work 40 hours and all these horrible call schedules, because the more patients you see, the more cases of the same thing you see, and the variations of how things show up is how you learn. And then it's like you can't recognize something you've never seen. So that's why it's those people that do the training in 2 years and then pretend like they see patients. I'm like, you've never seen any of this. How can you did like a thing online and have never seen a sick kid. How could you know this kid is okay or not?
Well, and to your point about protocols, I mean, patients aren't always exactly truthful, right? And so,
Or exactly the same.
right. So somebody, with condition A is going to come in and give you one story, and another person with condition A is going to give you a different story, and until you've seen, 30 of condition A, and then you can start figuring out, well, what is the common, like fibs or exaggerations, and then it will prompt more questions from you because you've already seen other people that are presenting with the same thing.
And that's the fun part of medicine to me.
It's almost being an investigator.
Figure out what's going on. And I can tell you that more than 50% of primary care is mental health. So a lot of times it's just talking to people. You get to talk to people and they feel better. They're like, duh. That's the basic of, it's the basis of medicine, is that relationship, where if somebody's having an issue, they can call you and hey, let's talk about this. And even sometimes I don't have to say anything. I just have to listen and be a person and be a human being. That's easier sometimes than diagnosing something. But that's what we don't have time to do in the big system, because time is money. And if your appointment is more than 10 minutes, you are not making money. And the whole time you get told as a physician, you need to see more patients. You're not making up your salary. So something's wrong. Either the system's wrong or the salary's wrong. It could be both. I even got to the point where I said, then don't pay me as much. They were like, wait, what? And don't pay me as much. I just want to be able to spend a half an hour in an appointment and not 10 minutes. I want to be half an hour to an hour with my patients. Pay me accordingly to the number of hours that I'm working, prorated to somebody that sees patients every 6 minutes. They couldn't, like, what? That doesn't exist. And I mean, years of that destroy your soul as a physician, because you're trying to do something and you can't. So every time you leave a room, you failed as a physician. And this kind of takes, it's kind of little, sucking your soul. And then at some point you just become a machine, and you just even sit with the back to the patient, right? So you come in and let me do this for you. So how are you doing today?
Right. You got to talk and chart at the same time.
Really? I mean, the rooms are set up so the computer is, so the physician is with the back to the patient. I'm like, who thought of this? Well, some being countered. Right? I mean, you need to see more. I don't need you to do eye contact and establish any human kind of relationship. And you can't like give a patient a hug, because that's like violating who knows what rule. And you can't take gifts from patients. What?
Well, and I
The
think
best
you
thing is
probably,
getting a gift from a patient because I know how important that is to them and to me. And they bring me food. I mean, Mexican food. What else? Like, give me tortillas. I'm like, oh, somebody made me tortillas is like the best, you
well,
know?
and I think it's probably because a lot of times those extras, I mean, you can be penalized for them. So it's not
Oh,
necessarily
yeah.
that you can't take them. It's that if somebody reports that you did, then
Yep.
you can be shut down, you can be penalized, you can get, like there's so many rules and guidelines that are
Yeah.
tied to taking insurance that
Hmm.
is the strings are like Pinocchio would be scared of how many strings that are attached.
It is crazy. And I mean, I do still all the training that is required by Medicare, even though I don't participate in Medicare at all, just because I want to know what's going on and, not break the rules. But some of the stuff is just dumb, honestly. It's like the self-referral. I mean, I can't like kickbacks and things, right? So you cannot refer to something that you have some sort of financial. I can see where that's important, right? If I had an X-ray machine right here and I said, "Hey Ben, let's do an X-ray right here in my machine," and I charge you $2,000, and then I'm making money out of the X-ray that I ordered myself, it's a conflict of interest, right? How are hospital systems created? The practices, the primary care practices can only refer. So when you work in there, is like, shh, but you can only refer within your system. I would get dinged all the time in the meetings because I didn't refer inside the system. I said, isn't that some sort of like violation or thing that you make me do the training every year if I'm self-referring? Shouldn't it be a more open market? And if some office is not very nice to my patients, then can I send them somewhere else? Nope, you have to send them here because, and they would give you graphs. I was always in the red. I misbehaved. And so, why are you referring out? Because they're nasty to the patients.
It's
Why would I refer to them? I
it
don't want to go to that office. The
it
patients come back and tell me, oh my God, that doctor you sent me is horrible. Like, I'm not going to send you to that person, right?
it's
And
wild that it's wild that you're saying that you were in the red because you were
Mhm.
doing what was best for your patients.
All the time.
It's just
So,
crazy.
so you get quality measures. So they say everybody's A1C. The A1C is a number of like a average of sugar. So every diabetic has to have an A1C of less than 7. Why? Because somebody decided 7, right? So I agree. It's better to have a better sugar because you then avoid the complications of diabetes. Well, my 85-year-old guy who's, can't see and hear and, has a prosthetic leg, I'm sorry, but his A1C, his sugar is going to be a little higher because the last thing I want is somebody like him to be dizzy because his sugar is a little lower, or his blood pressure, right? You have to push the blood pressure under 120. So then they did research after a couple of years of doing that. And the amount of old people with hip fractures was crazy. And if you have a hip fracture, your mortality in a year is like 80%. So do no harm is the first thing we do as physicians. So I am not going to push the number just so some person can get some money. And I would, in the meetings, I'd be like that. I'd be like, I am not pushing the A1C lower. And I'm not forcing people to have tests they don't want to have. So if somebody says, I don't want to have a mammogram because I don't care, fine. Are you aware that we could catch something early? Yes. You aware that you might miss a cancer and then die? Yes. You still don't want to have a mammogram? No. Okay. And we would have these discussions, right? I mean, I'm always like very direct. I'm like, are you sure you want to avoid doing that test? It's not a big deal. It's not, just get it done. Oh, okay. I convince people just for their own good. But as a physician, you would get dinged financially. So your salary is attached to having that number lower of sugar, lower of blood pressure, and how many people do their tests. So guess where your incentive is?
Well, and
In those things, so you get paid more.
to defend a little bit on the at least the hospital slash medical group side of things, it's not like they're necessarily dinging you, it's the insurance companies that are dinging them. And so they feel, I mean, it's almost like a trickle down scenario where the penalties end up falling on the physician because you're kind of the lowest common denominator, but they're starting at whether it's CMS, Medicare, Medicaid, or at the insurance level, because they think, it's cheaper to insure a person if their A1C is below 7 because there's reduced risk of diabetes. So they're looking for what's the cheapest way to insure people, and then so really, like, healthcare in general is about money. You're chasing the lowest potential spend and trying to apply that one size fits all to everyone.
So it completely eliminates patient autonomy because you don't have a choice. Your cholesterol's high, you're getting a statin. I don't care if you want to take it or not. I don't care if really the evidence shows that it's going to make a difference in your life, because it's kind of wishy-washy. Maybe you haven't had a heart attack. Yeah, you may have, cholesterol's high, maybe you smoke. Do you really need this pill? I'm not sure. When the evidence is not perfect, in medicine is none of it is perfect. Everything is risk, right? So, okay, you can reduce your risk by 10% if you take this pill. Is that a lot? Is 10% a lot or not? Well, it depends, right? So when you remove the autonomy of the patient on one side, right? It's like you don't have a choice. You have to take this pill because otherwise I get dinged if you don't take the pill. And you remove on the other side the physician's brain, because it's all a protocol. You get this cookie cutter, production line medicine where you come in. How old are you? Oh, you're over 50. You need this test. You need this medication. You need to be on aspirin. You need to be, and nobody asks you, did you want to do this? No. Do you really need it? I'm way more hands off now than I was, because you start practicing that way. You don't even know it. That is like kind of your little good and bad person, right? And it's like, you have to do this and you have to do this. At some point you think that's the truth. So like you step out of that. So like I'm out of that now. I'm like, why do we practice like this? Why do we put everybody on a statin? Let me go back and review the evidence. Okay, then I read all the studies I can read and educate myself and say, oh, it's not black and white. It's not you have to have this. There's a little tint of gray here. And what if you have this? What if you're a guy? What if you're, a woman, but you're before menopause? I mean, there's all these little things that give it more flavor. And then you can actually make a true educated decision with the patient of, should you be on this medication? Should you do this treatment? Should you? And it's so funny because now that I am out of the system, the patients want to know what I think whenever any specialist gives them a treatment. What do you think? I'm like, oh, thank you for asking me.
Yeah.
I'm like, just a little primary care doc. I don't know all the details of things, but I try to like, okay, if this cardiologist is telling me this is what you need, then this is what you need to do. And maybe I go into more detail of why, because that happens, right? Patients don't get explained. Why do they want
because
this?
That 10 minutes.
This is very important for your health. And you explain why, and they're like, oh, well, I wish they would have told me that. Well, nobody has time.
Right. So where do you see or have you seen direct primary care growing? Is it is it something that's, because I think that there is, I think we've had discussions with people that we know that are physicians, and there is a hesitancy of like, well, I didn't go to medical school to become a business owner. Like that's so out of my wheelhouse that I'm just going to stick with the current state because it is what it is, and at least I get to just practice medicine and I don't have to worry about billing, or I don't have to worry about, setting up an office, paying, all that stuff that the thought is in their head that it's too cumbersome and it's too much work, and I just want to see patients.
It's so funny because it's way less. So the management of an office like this is way less work than the billing I had to do on my day-to-day insured practice. Like just billing for a visit is way more work than what I'm doing now business-wise. Because, well, first of all, I mean, I was the first one in town, so that maybe there was a little bit more of effort to get it going. But right now, tons of people know about direct primary care. It's everybody be like, oh, that's like that person here and there, oh, I heard about that. There's a new doctor in town doing that. When I started, at least in West Michigan, there was nobody. And now there's at least 4 in Grand Rapids. There's 1 in Holland, 1 in Grand Haven, Traverse City. There's a guy who's going to open in Marquette. There's a few in Lansing, tons on the other side of the state who are like faster at adopting things. They're more adventurous than over here. There's tons, and Michigan is not one of the fastest growing in DPC. So when I opened, there were about 600 practices in the US. There's over 2,500. It's not even, I mean, it's just, because once people get over that little fear of a business, so I always tell them, it feels like you're going to jump off a cliff, but when you jump, it's just like a little step. It's just like a curb, almost like you close your eyes and you just take a step and you just, oh, that wasn't so bad. It's that fear that doesn't allow physicians to be independent. And because it's been ingrained in your brain that you can't do it on your own, that is super hard, super expensive. You're not gonna make it. What do you think people told me? You're not gonna make it. You can always come back, was what one doctor told me. A colleague said, you can always come back. Like, why would I come back? I'm not coming back ever. If that doesn't work, I'm doing something else, because this is no life. This is no way to live. I never got to see my family. My daughter hated me. I would come home and she'd be like, and who are you? Because I would be stuck to the computer. And now it's like, Mama, and I take her places. And, if she has a day off of school, I could take a day off and spend it with her. We can go watch a movie and, just hang out, do people stuff. We're people too. And I think we forget that, right? As we're just cogs in the wheel. You just have to see more patients. You can see another 2 patients at the end of the day. Why not? It's only 2 patients. Yeah, it's 2 patients that are going to add a bunch of paperwork and labs and referrals and all these things. And it's not just 2 patients. It's a lot more work. And they keep pushing and pushing and pushing. So the physicians in the system, and I have lots of friends that are in the system that I'm trying to like pull out. It's like the frog in the boiling water, right? You just crank the temperature little by little, and they're just sitting there boiling. If you threw them at once, they'd be like, oh my God, this is horrible. Yeah, you don't see it because you're inside. You're inside and you just don't notice how every year there's something else. Now you have to go to this meeting. Now you have to do this quality crap. Now you have to do this other thing on top of your work. And now you have to supervise PAs and nurse practitioners. And guess what? It's your license on the line and you don't have a choice. You have to supervise. We don't care if you don't want to. And guess what? You don't have time to do that. So then you just kind of trust that some, nurse practitioner that you've never worked with is doing the right thing. You don't know.
When do you think that direct primary care is going to be so disruptive? And that maybe we've already hit that plateau where traditional primary care insurance companies are going to start seeing direct primary care as a threat. Because I think for a while it was kind of like it's a little irritating, but it's never going to succeed, right? Everybody has Medicare, but I wonder if it gets to the point where, again, because it's government and regulatory regulations usually are used as a weapon against competition, then they actually are to benefit patients. But I can see the Blue Cross and petitioning the government to say these rogue direct primary care offices are dangerous and people are getting whatever, and they can say, well, you to practice medicine you have to take Medicare.
Yeah. And so there's always that fear. There's always that fear, of course. But you know what? YOLO, right? You live once. I mean, if I were to like decide my life based on what the government does, I wouldn't do anything all day long, because I'd be like, what? Now I have to do this other. Oh my God. We get all the time as physicians is now you have to do a module on, what's the new thing? The
diversity.
You have a bias.
Diversity.
Implicit bias. So now I have to do 3 hours of implicit bias training. because they decided that, we need it. Okay, fine. And there's tons of things get thrown at us. Okay, there's another thing I got to do. Check on the box, get it done. I don't care. There is that fear of, and every time there's an election, all the DPC doctors get a little like worried, Um, I mean, I think that ones that have been longer in this are like, it's fine. We'll always find a way. So I think it's getting to a point, the growth of DPC is getting to a point that I don't think that the government can shut it down, because now the patients would complain. 5 years ago, yeah, maybe, because there were like 600 practices, so you could just squash it and there weren't that many patients. But now it's thousands of patients that love this. So the patients are the ones who are going to defend it. And I think it's a little like, I have another friend who's a physician, of course, kind of your neck of the woods, kind of libertarian in his views. And he said, this is a little like homeschooling. When people started doing the homeschooling, it was like, oh, it's just a couple of, out of the woods kind of crazy people. And then all of a sudden it starts growing. You can't shut it down if you wanted, because now the parents are not going to let it happen. So I think the same way direct primary care are breaking free from that big system, it's getting to a size that is not so easy to squash. I think the difficult thing is it is not scalable like the system is scalable, because the system, you just put a building, throw a bunch of people in there, and you can just see patients because it doesn't require any like personal thing. DPC is so personal that it is hard to scale. Every time anybody wants to do it big, and one of the hospital systems here in town tried, they opened the same week I opened and they closed in 2 years. They couldn't do it because you cannot make this into a big office, because then it loses that. The moment that I cannot answer my own text to the patient, answer my own email, and I need staff to do that for me because I'm so busy. I have 1,000 patients, or there's 5 of us, 5 doctors in the office, and they put you in an appointment with whoever's open, and then you become the same. So that's why it's so hard to scale, to make it bigger, because it has to be done like one doctor at a time.
Yeah, well, I mean, it's almost like you wouldn't want it to be any bigger than that.
Exactly.
It like you'd want it to where, a town like Battle Creek where we are right now, I think there's 55,000 people here, around there, and have like 10 DPC doctors, to cover the town. I don't know, probably more than that.
Benefits person when I opened, super nice guy, and this is the guy that so it's a TPA, so he would get companies the benefits, right? So most companies that are there, I think more than 50 people, have to have insurance, and they're when there's these huge companies, they're all self-insured, so they pretty much decide what is covered, not covered, and then they go work with Blue Cross or with whoever to manage the insurance, but it's basically they're paying for it. So I remember talking to him, and super nice guy, and he's like, oh my God, I love this new thing. He's like, that's the way we should do it. And then it was just me, right? So he just like, call me when there's 10 of you, because I could fill your practice in one day. So yeah, you can't, and it's hard to get doctors to do this. You have to do it one at a time. You can't just like grab 10 doctors and do it. It's not that easy, because everybody's got their own ideas, their own fears. They got their own debt.
I mean, the lack of stress has to be a major selling point, right?
Oh, it's awesome.
Yeah.
It's so nice.
I mean, time with your family.
To be able to sleep and not cry to work every day.
Yeah.
Well, but at the same time, it's great because I can speak from the patient's perspective. Like, I would very proudly grew my own kidney stone this week, or no, that was last week. And
Aww.
yeah, I was like, oh, that's just great. But to be able to, even though, I was up at 3:00 in the morning, writhing in pain, I could text you and say, this is what's going on. And like, who can do that? You know, I mean, we talk about concierge medicine, but even with concierge, I mean, who has that ability to, you know, to just have a conversation with their doctor, say, this is what's going on, this is what I think is, you know, potentially happening, what do you think? And to have that back and forth. I mean, I was like, all right, let's go to the emergency room, and right, you know, while I'm, you know, before I'm even discharged, I'm able to text you, as like, oh, it's this and it's this. And
Yeah.
like, to have that connection with my physician, like, I know most people these days, most of them haven't even met their primary care physician, right? They're only seeing mid-levels. And
Well,
and
and
that's
you
great,
don't have
but
to, when you text me, you don't have to say, "Hi, this is Ben DeJong, and this is my date of birth, and I'm having this issue," and then you have somebody reply. I mean, I obviously see your name in the text because it's through the software, through the EMR, so I know it's you. But you don't have to say who you are. When we chat, you don't have to tell me. You know, you say the girls. I don't have to look up. See what is the girls? You know, it's so different. I mean, I'm not up at 4 in the morning answering the phone because I also need my beauty sleep. But you know, when I get up in the morning and look, and everybody knows they can text me at night, and I'll look at it in the morning, and then I can see, oh, somebody's having an issue. Well, I might not open the office until 9, but if I'm awake, I'll check the text messages and say, okay, somebody's having an issue, or the kids got a fever. Can I see them? And I can see them. I'll see you at 9, you know, so I can have breakfast and get my kid to school. But it's so funny because it's not just you. Obviously, you don't see on this side, but at the same time, I've had like 3 people in the hospital this week that I've been able to manage. They're in the hospital and they're texting me, "Hey, what do you think? They're putting me on this medication," or, "Oh, the specialist just came in and said this. Can we talk?" And then I can call them and say, "Hey, okay, what did they say? Let me translate that for you." And just little things like, you know how you don't know the rules, but supposedly, so if somebody gets discharged from the hospital, Medicare wants them to be seen within a week, right? Good luck trying to get in. I mean, I couldn't when I was in Florida. Sorry that they're sick, but what do you want me to do? Is like, well, you don't need to eat lunch. Let's just squeeze them in your lunch, or you don't need to go to the bathroom. So you can put them before the day or at the end of the day. And so you just pretty much are at whatever mercy of whoever says. Well, I had a patient who was in the hospital this past week, and we're chatting back and forth in the text, and the wife's super appreciative. And she's like, "Oh my God, thank you for helping." I didn't really do anything except just tell them, okay, ask them this and make sure the hospitalist puts like home care so we can get home care going. And then I'm still going to see him this week. But I did all this management while the patient was in the hospital, and I love it. I because I'm more in the loop of what's going on. And then I can also help the patients decide things. They'd be like, "Oh, they're wanting me to do this. What do you think?" Don't know that I would do that. You know, I know them better than the hospitalist that gets to see them in the hospital for one time. So I'd be like, you know what, let's talk about that when you come out, because I don't know that I agree with that. And so we can have a discussion. I can give them my opinion. They can do whatever, you know, they don't have to do what I say. I don't get mad if they don't do what I say. Well, it hurts my feelings. But I'd be like, you know, you really don't need that test, or you do need that test that this person's asking you to have. And then we can discuss and kind of go through the details. But it is a lot more. I think, even though the stress is way less than in the system, because obviously I don't have 3,500 patients, it is more intense because if somebody's sick, I'm with them. I mean, COVID was brutal because COVID lasted forever. So then somebody's sick for 3 weeks, and then we're constantly talking for 3 weeks. And it's not one person, right? It's all these people are sick at the same time. So that was a lot as far as the intensity, and a little bit of the fear of like, we don't know what's going on, and there's no treatment. And like at the beginning, right? There's no treatment. There's nothing I can do. And I would, you know, I bought a bunch of pulse oximeters. I'm like, come to the office and I'll give you one, and just take it home and we'll chat. You know, let's text how your oxygen's doing and how your symptoms are doing. And it was pretty intense, but it's fine. throw
Well,
another pandemic.
I think one thing that people don't quite understand is that traditional medicine, you have to practice within the guidelines of ICD-10. So
Yeah.
ICD-10 is what you can charge insurance for anything you do as a physician or as a caregiver or a practitioner, any of things of the above. So that's why you can't just text your physician, because there's not an
This is not
ICD-10
paid for.
code that
Yeah.
they can get reimbursed, right? And so people, I think they don't fully understand how controlled the system is by not necessarily by insurance. I mean, yes, insurance dictates a lot, but that's usually dictated by Medicare, Medicaid, and the government, right? So this is kind of cutting the cord of those restraints between a patient and their physician. And you don't have to, you're not stuck on those guardrails. You're not stuck in that path. You all of a sudden, you're not a number anymore. Now you can be a person, you can be a patient, you can have a relationship, because you can't. The system doesn't allow that unless you go to church with your physician or your neighbors with them. You just don't. You can't have that relationship because it can't be built. And
well, a lot of times you don't even know who they are,
right,
because you get put with whoever's open. So then you have to explain again everything. It's like, do I have to explain everything? Oh, it's like exhausting and so impersonal. It's so annoying. It's like so crappy.
Well, and it's like, if calling a primary care office, most likely you may never actually be able to speak to somebody. They throw you into a phone tree. If you need medication refills, press 1. If you need to leave a message for a nurse, press 2. Like, and then you just hang up and you sit and hope that you get a call back that day. And
yeah, most places can't call the same day.
Right.
I went through that. I mean, it was impossible for the nurses to catch up.
And just to juxtapose that from your business model is, I think you have a nurse that works for you, but
So
usually when you call the office, you're answering the phone.
Yeah, I answer the phone. Of course, if I'm like seeing patients, I'm not answering the phone, but I have a nurse that works, if she works 10 hours a week is too many, from home. So she will help me if somebody needs a test that needs to have a prior auth, because I hate prior auths. I think my IQ drops every time I have to do one. So I honestly just
which is a huge part. That's a huge part of primary care, right? Or of healthcare in general.
And I try to convince people to not use their insurance if we can. So I'm like, your deductible is $7,000. You're going to pay the whole $4,000 of this CAT scan if you use your insurance. And some people are like, that's okay, I want to meet my deductible. I'm like, okay, it's a choice, right? I try to convince them, let's go outside of insurance and let's do, and I a lot of time get my way, because then people can just go and get an MRI for $300 or $400 cash, not on this side of the state, because there's a lot of competition and who that squashed all those little guys. But if you see the how we're like stuck on the insurance, right? It's like, I don't care, I'll spend $4,000 so that my deductible's met. That makes no sense.
Yeah, it's almost like
pay $400. It's your money. You're never gonna meet your deductible, because you're just gonna be close, but never gonna meet it, and you're still paying 20% after you meet it. This is not free. There's nothing free here. So I think that when people start seeing those things, and I try to show people, I say, hey, okay, let's see how much it is to do a scan cash, and then let's see how much it is in the hospital. You choose. And a lot of people, when they go through the system, then they like, oh my God, you're so right, I ended up paying a ton. And it's not just that, it takes forever to schedule, and then they don't call you back, and it's all these inefficiencies of a big system that they can't fix, because it's bigger and bigger and bigger, and they keep merging. It's like these when you put like water, and then there's water, and they just like the blobs just get together. It's like that, right? It's just the systems just keep merging and getting bigger. The bigger they are, I think the more inefficient, and then the more impersonal. Now you're gonna be some sort of like airport that you go through, and it's like a futuristic movie, but just kind of crappier.
Dystopian.
Do you think is it even possible, or will the system even allow direct primary care to eventually replace the traditional primary care model? Because I think there's always going to be, I mean, insurance. The way that I always look at it, insurance
I
should
don't
be.
think we're ever gonna replace them. I'd be awesome, but I don't think so. It's still a big money maker because that's the entry point for specialty testing and everything else.
But
So
you're still sending the referrals to specialists and to, you know, potentially larger like diagnostic tests.
but I decide where to send them. So that's where they lose the control, and that's not gonna be, you know, because I can send to any of the 3 hospitals in a day. You know, I might have one that I prefer, but if somebody says no, send me to X, Y, and Z, okay, fine. I don't have any gain in sending them one place or another. I just don't know sometimes where it's faster to get in, or which
But
one the doctor is nicer.
I think
which one, like a surgeon, right? Is like this surgeon is the surgeon for this issue,
right.
even if maybe their bedside manner is not the greatest, but they're really good at what they do. And if I, by knowing these doctors and knowing each other and everything, I can send them and say, oh, you're going to love this doctor. They're awesome. And, you know, you try to like build it up a little so that they are not scared to see a specialist. Sometimes I say, don't worry, you know, the doc is going to come in. You're going to be like in 2 seconds out. I'll explain everything to you later. I'll read the note and I'll use that. And then I'll explain everything, but don't expect this physician to explain that to you because they don't have time.
Well, I think for me,
you're a surgeon and surgeons operate.
Right. My kind of dream world is that direct primary care can hit that plateau where it's going to be unstoppable. And I really hope we're there already. But if you get to that point, and because I mean, primary care has been dying for years, and at some point it's going to just collapse, because I mean, right now we're facing, like, you can't find MAs, no less nurses, no less physicians who actually want to practice, and so they're dumping more and more nurse practitioners. And
well, that's what primary care is going to become, is simply a squad of mid-levels trained, you know, who knows how, who are going to refer. So that's their job, is to capture that person and see where they need to be seen. So that initial contact doesn't need to fix anything. They don't actually fix anything. They'll refer everything out. So when you've worked with a mid-level, and there's some that are good. I'm not saying they're all horrible, but
they can only do so much.
The good ones are like the exception. The majority are kind of just in the middle ground. They're trained to do a certain thing, which is do an assessment and see where people need to go. They don't even treat like blood pressure or diabetes. Every person with blood pressure gets referred to a cardiologist. Everybody with diabetes to an endocrinologist. So then you want to send somebody who has a real serious, issue to a specialist, you can't get in.
Right.
Because they're seeing all these things that should be taken care by a primary care. And sometimes the patients are used to this. So they'll come see me and say, oh, I have this, can you send me? I'm like, not really. Let's see why. Let me take care of the issue. If I get to a point that I can't, because it's the end of my training, I will send you. But there's no reason for you to see an endocrinologist for this. And that releases the schedule so that then I can send the person that really needs to be seen by a specialist who I can't take care of. So the system I think is just going that way, because I remember when I was employed and they said at some point you are going to have, each physician is going to have around 8 mid-levels that you're going to supervise. And you're going to have your team. You're not going to see patients. They're going to see the patients and they're going to just tell you what they're doing. Oh my God, that's a nightmare job. I'm like, what do you mean I'm not going to see patients? That's the place I love to be. And it actually what saves, I think, a lot of the docs that are in the system, is that they are still seeing patients. So they still get a little bit of that.
You're not a physician, you're a coordinator at that point.
Yeah,
You're
it was
coordinating care.
horrible. It's like, oh my God, that's a horrible job. I don't want to do that job. I don't care how much you pay me. Of course, they pay, incredible amounts of money, and so people go for the money. You just kind of stuck. But then it's tied to something. It's not just free money. It's like you're never gonna be able to practice anywhere else. You belong to us, and I'm gonna tell you what to do, where to go, all these things, and then you're not free anymore to do anything.
How
It's not. It's like you can't even decide your own CME, like your own medical education. You
is that?
have to do this MOC determined by the American Academy of whatever. I can't decide what I need to review in my. Maybe I need an update in cardiology. No, no, you need to do this other training on whatever they decide. So it's all like it's all together. It's pretty impressive how the system like feeds itself as this beast that kind of just like ping pong around,
Is that through like employment contracts that they? I mean, because I mean to exude that level of control
Oh,
over
it's crazy.
over a professional's career,
Mhm.
it. I mean, who would
It's
like who the
so
hell would
so
want to sign that in the first place?
the difficult thing is the contracts that are just terrible. Well, first of all, who understands the lawyer mumbo jumbo?
The
I
legalese.
don't. And you have a lawyer, and they'll review it and say it's pretty standard. It's a pretty standard contract, and that's what it is, right? The contracts in the doctor world are horrible because they have a no compete clause,
Mhm.
and it's to me it's so funny that lawyers make no compete clause for doctors, but they don't have no competes, right? You're a lawyer, you work for a firm, tomorrow you leave and you take all your clients with you. But physicians, we can't. So the lawyers came up with this wonderful no competes that, and some of them are horrible. They're like 50 miles from any county that has a facility of that name. Oh, so you have to move out of state. So I actually, in the last year, and this is the first time that I've seen this, I've talked to two different physicians in the last year. I mean, I talked to a lot of doctors that are trying to break free, but two that quit and had to move out of state because they couldn't work in the state because of the no compete. And a lot of people say, well, the no compete, nobody's going to enforce it.
That's not
Are you going to
true.
be the one to risk getting chased by a group of lawyers from a hospital group? I don't know. They're pretty scary. And they have a lot of money, and you don't. So they can just throw a bunch of lawyers at you and not allow you to practice. They
I've
can sue you for
so
breach of contract, and you're done.
I've been in the medical industry. I'm not currently, but before the job that I have now, I was in for like 10 years. I worked in nursing homes, and then I started delivering home medical equipment. I was in that business for like 7 years. And those no compete clauses, like the idea that they're not going to be enforced is silly because I've seen nurses aides nurses aides who make like $12 an hour, and
Yep.
old employers have gone after them because they're working for their competition. I've seen there was a guy who delivered for us at CareLink, which is the DME company I used to work for, and uh, he was just a delivery driver. That's it. But
Mm-hmm.
the company he used to work for sued him because he started working at CareLink, and it was all because of no compete clauses.
Yeah, I think it depends. It's by state. I wouldn't. I was very careful when I quit. I did have a no compete, and I respected it because, and it's a small town, right? I mean, I wouldn't want to go into a legal fight with a hospital that I have to send patients to. I
And
have to
and
work with them.
and you
So
and
even
nobody
though
has the finances to be able to fight that against a
no,
hospital.
there's no way I would like just quit and go somewhere else and
Mhm.
hide and change my name. I so even though I criticize all the hospitals are the same. This is not a particular one. They're all the same, and they're all the same in all the whole country. Because when we get together, all DPC doctors, we don't talk about the system because it just makes us sad. But you can see that the problem is the same everywhere because all the people that have broke free is the same story, and I hear the same story all the time. It's like, oh my God, and now they're making us do this and I'm like, it's like deja vu of the same thing. When you're so stuck in a system like that, of course it's so scary to break free, because now they're gonna sue you. Really, we need doctors. We need more primary care doctors, and they can't practice here. They have to move somewhere else. It's so hard to get into primary care nowadays. Like, it takes you about 3 to 4 months to get into primary care right now. And I stopped taking patients. I can't. I mean, at some point it's like, okay, when I see myself like so busy that, for 3 hours I couldn't even see who called me, I don't like it. So then I pace myself too. I don't like, because there will always be more people, because the need is huge. So it's so funny when I'm trying to talk to my friends and get them out of the system and say, oh my God, you would just hit the ground running, because nobody can get into primary care right now. And now people know about this. So I could fill you, because I every day have to say no to somebody who wants to be a patient. And I'm like, sorry, I'm not taking patients right now. And I, on and off take patients, but I mean, pretty much COVID, I took way more than I wanted to, because I couldn't say no, because it's the middle of a pandemic. So everybody's calling sick, and I'm not going to say I can't see you.
Yeah.
And so I had like too many. And so I'm like, okay, I need to stop taking more, because it's a lot more work. And I don't want to be working all day long. I want to be able to do other stuff. That's more personal, it's like, yeah, maybe somebody wants to work and see 1,000 patients. Great. I don't, because I like to be able to take time off. And if I go to a conference, I don't feel it. If I have to go to vacation, that I did this year, that was so awesome. I took 3 weeks in Spain. When could you do that employed? And when I was in the system, there's no way you cannot take more than a week at a time. You can't. Even though you get like 5 weeks of vacation or something, you can't take more than a week at a time. And then when you come back, you get punished, because your inbox is like 10,000 things and you will never finish it. So I always dreaded coming back from vacation when I was employed.
So for people who are like looking or like the business model, and they're like, man, I really want that. Even though, you're full from taking patients, does Direct Primary Care have a website where they list all the physicians that
Yeah,
are?
there's a couple of places where you can look at practices. There's one that's called dpcfrontier.com, and they have all the legislation and all these other questions that people want to know. Is this even legal, kind of things? People ask me, is this legal? Are you even have a license? I'm like, yeah, right. Whatever.
So is that the best place for people to go to look for more?
That's I think the biggest list. There's another that's called the DPC Alliance. This is actually the first physician group of all DPC doctors that was created just a few years ago. And it's awesome, because people belong to the Academy of Family Physicians, or the internal medicine physicians, or the pediatrics. We all belong to those groups, but they're all hospital based. You go to a conference and it's like, oh God, just shoot me. It's like, please get me out of this conference. It's horrible. And you go to this group, and it's all, we're all DPC doctors. It's kind of nice. And we are able to now there's enough of us, first of all, that we could set up an alliance, and we actually have an organization that, we have a list so people can go in there, and there's education. So now if somebody wants to break free and doesn't know how to do it, we have tons of stuff listed. And there's like masterminds and conferences, and they're now working to see if the nuts and bolts conference is done together with the alliance. It's kind of nice, because now finally we have a voice within medicine. Also, we're able to get pricing, which is nice. So one of the nice things of being many is then you can negotiate prices for labs and medications. When it's just you, man, the reps just laugh at you, because they're like, how many patients are you gonna have? Oh my God, that's so cute. So they're like, there's no way they're gonna give you a price, because you don't have the volume for it to be attractive. So to them is like, well, you don't have enough patients. Well, if you get 300, 400, 500 practices that do DPC. That's a good number of practices. So then you can get better things. So we get now much better labs, medications, and supplies, and other things that before we couldn't get, even like translation services. I get a discount because I belong to that group. So that works a lot, like a lot of the medical groups that because you participate in the group, you can get like better malpractice, for example, better rates, because then it's negotiated as a group. So when you're saying, is this growing? Oh yeah, definitely growing. It's not, obviously, if you see, it's like tiny compared to the big machine, but it's big enough that we're able to do a lot more than 10 years ago. So yeah, when somebody wants to look up stuff, I mean, the DPC Frontier is a great website. The DPC Alliance is a great website, an organization. And then we have conferences. So there's the DPC Summit that is done by the AFP. That one already happened. And then we have the Nuts and Bolts, which is now in November in Dallas, which I'm going. And because I always like go to that one. And I'm actually speaking at that one this time.
Cool.
Which is the next generation. I feel like very, very honored and very old. Because now it's like, okay, now it's time to give to the newbies and to help them figure out where to go and what to do. And always, I'm kind of the grandma of West Michigan. So every doctor that wants to do this, they always call me, and I always talk to them. So maybe it's like, okay, well, let's talk on Saturday, so I'm not like with patients. And I just tell them, they always ask the same thing, so it's kind of easy to do. And they always want to know, so how do you get this, and where do you do that, and it's always more the practical stuff. It's how do you get an office, and how do you get furniture, and because we know how to do the doctor thing. That's easy. To me, not having to bill, it's so freeing. It's like, oh, I don't have to do any of that, so it's a lot easier.
Is there a phone number or email address if there are any physicians that are listening that would like to maybe pick your brain or figure out what?
They can always go through my website, which is dpcwestmi.com. In there, if you write a message on the website, it goes to my email, and I'm the one answering it. And that's sometimes how physicians contact me. It's like, hey, I'm practicing in Grand Haven, and I'm thinking about this, and it's kind of nice to be able to talk to other docs and be able to show them. And now it's like, oh, you've been open for a year or two, and it's so cool. Now there's other doctors that are starting to help the others. So it's like a 2 generation, so the people I helped are now helping others. In medicine, it's always been like that. We always help each other, and it's always like, see one, do one, teach one. So we still, why not? And I help everybody, and if they want to know how, I tell them how. I don't charge for that. It's kind of funny that some people make money out of that. I think it's kind of against the same growth, right? Now you made it into a business opportunity to show how you do a DPC, and it's a no-brainer. It's so easy. People, I think, are more afraid because of what they've been told. It's like, you are never going to make it because you don't know how to do marketing. Yes, you do. You can talk about medicine. It's not that hard, honestly, and especially if it's a town where it's not that big, like Grand Rapids is not big. Like Battle Creek, you guys have Dr. Mark Mahalka is in Marshall. So, and he's awesome too. He helped me. So when I opened, I met with him.
He's a DPC.
And I remember, he's just laughing at my fears. So funny.
He's a DPC.
Yep.
Very cool.
Yeah, he opened before I did, maybe a year or two before I did. And I sent him a message through his website. Mm-hmm. And then we talked. We met for coffee in, I think we met in Kalamazoo, so it was like halfway. And I asked him the same questions that people ask me. And I remember he's like just laughing. Oh my God, this is awesome and so easy. And I couldn't believe it. I was like, wow.
How long have you been doing this?
5 years.
5 years. Okay.
5 years, yeah.
Well, let me ask you one more thing, and I think we should
close up. Yep.
All right.
I can talk forever, as you can see.
We'll definitely have you back on, so don't worry.
Yeah, this has been great. This is such an interesting thing to me, and I love thinking about the future of this kind of medicine, because I mean this sounds like a game changer, you know.
Oh, it is.
But anyway, the question that I wanted to ask you is, what was the catalyst, whether it was an event or a person or something you saw? What was the thing that happened in your life to make you get to the point where you were like, I want to be a doctor? What was that thing in your life?
Oh, to be a doctor?
Yeah.
So I always wanted to be a doctor, and I don't have any doctors in my family, which is weird. I was like 7 or 8. I always so if you see like our family movies, it's so funny. Like my mom had one of those like cameras, and I had my little doctor kit. So then my brother, very dramatic, would like, there's an accident, and he would just like drop in front of the camera, and then I would come out with my blood pressure cuff and call the doctor, and I would show up, and I was like 7. I mean, I don't even remember when I started wanting to be a doctor, but I think one of the things that really pushed me, that impressed me when I was a kid, was that I went to an orphanage in Mexico City, and I get like choked just thinking about it, because I saw like the worst environment you can see, of kids like strapped to beds, with who knows what illnesses, genetic, malformed. I mean, it was like, I don't know what they were thinking, taking us to an orphanage at that age. But that's I think when I kind of knew that this was real. It was a wake up thing of saying, this is not just playing doctor. This is what I want to do. And I wanted always to do pediatrics. And I did the combined medicine pediatrics just because I don't think I can see kids all day long. I think I need the adult conversation. Kids are fun, but it's like, okay, come on, get out here. There's so many babies you can see in a day, so I like the variety of the adults. But I think that marked me. I think seeing, and I'm from Mexico originally, and in Mexico, physicians, it's a little different. I think people that want to be doctors in Mexico have a little more of that, helping people without money in the middle. We just, I think we're trained that way because there's so much poverty, because there's so much need, that you just, when you're a doctor, you don't care about the money. So you just train that way. And I think I brought that with me, because I don't really care how much I make. It's not, to me, medicine is not a business, even though my office is a business. I help people that have no other way of getting care. So we're kind of the net of the net, because people that are undocumented, that's the people I see, people that can't get insurance because, and this is not just undocumented, but regular citizens that cannot get insurance and cannot get seen in an office because they don't have insurance. That's the sweet spot.
Which is funny because
different, right?
Yeah, but it's kind of funny because those people who don't have insurance, all of a sudden they escape the rat race of American healthcare system, and so in effect they're actually getting way better care than if they had insurance, which is kind of one of those kind of weird life things, like, well, I didn't have this, and so, but I'm way better now.
One of the best, when people say, well, people need to pay you so that they value you, and there's some, I get into discussions with physicians all the time about this, of like, you should increase your prices because otherwise people don't value what you do. I'm like, that's not what I see as the value of a patient telling me that they value what I do. What I do see is when somebody's a patient and they eventually get insurance. Maybe I saw them when they didn't have insurance and were one of those people that were really struggling. And then all of a sudden they get insurance and they say, I got insurance, but I want to stay with you. Can we still stay as patients? That's like the best. Or I want to stay, but I also want my cousin, all my family to see you. And I have families that I have like 3 generations this way and 5 this way, where I see everybody in the family and they keep bringing me more family members. And that is to me the best reward, is not the money. Do I try to make money in my business? Yes, because I also have to pay bills and live. But I have also other ways, other venues, like you've seen, that I, open more space in my office and now sublease, and I do other business things so that I don't have to worry about the patients. And so some people can't pay me, and it's fine. And so don't tell that to anybody, but it's true.
I didn't hear anything.
If you're in a big hospital practice and somebody can't pay, sorry, you're going to get a bill and you're going to be sent to collections. And so having, as a physician, to say, I can write it off, and I just write it off. I don't have to ask anybody. I just write it off.
I really like how at least for you, you've structured your own incentives to revolve around actually caring and actually giving a shit about your patients. I love that. I think it's great.
Mm-hmm.
I think what you're doing is great. I think this whole, burgeoning industry is great. I think it's all positives from here on out, unless, the federal government decides that they don't like it anymore.
They can shut us down, and then I'll be like, I do something else. But
or
be underground, right?
Run your practice out of your garage or something. Like, what are they going to do if they don't know?
Exactly. Nobody needs to know, right? You're up in era talking.
Yeah.
Maybe some other bar.
All right. So I have one final question. It's a 2-part question, and everything that we've talked about so far pales in comparison to the importance of this question.
Uh-oh. What
is your favorite and least favorite medical drama on TV?
My like best ever is Scrubs.
Hell yeah.
Because Scrubs is like, that's how medicine is. Yeah. There's always the fight between the internal medicine and the surgeons. Always
a creepy janitor.
The birds and the jogs, always. And you feel like little like that, like you have no clue what you're doing half of the time. Mm-hmm. And the nurses are like bossing you around. Totally Scrubs. ER used to be like also my show, but it's George Clooney. So I mean, yeah, that's a little different. My least favorite show is House.
Really?
Yeah.
Oh, that's interesting. Yeah.
House, and what's the other one? The Grey's Anatomy.
Thank you for saying that. My wife loves Grey's Anatomy. I hate it.
No, it's a soap opera.
I watched like a couple. I'm like, oh my god, this is horrible.
Yeah.
So House, it is so not real.
Yeah. I think that's what I love about House, is because it's so crazy.
the same resident who knows what kind of residency they're doing. Mm-hmm. They see the patient, they take the patient, do the MRI, and do the surgery, and I'm like, what? I mean, it's like not realistic at all. I mean, I like his personality.
Yeah.
Like I like how he says it's never lupus. Mm-hmm. I say that to my patients all the time. Like, it's not lupus. So, and Grey's Anatomy, too much drama.
Yeah.
And there's way too much sex. Like, that's not how medicine is. Mm-hmm. Like Sex in the Closet. No, nobody's got time for that. Rounding scene patients is like,
you don't have time to pee.
Yeah.
Like,
no. You can't get into the closet because
I don't think any of the doctors are having sex in the cots that they have there whenever they're pulling all-nighters.
All that between attendings and residents, that doesn't happen.
Yeah.
No.
They're exhausted.
No.
Well, is there do you have any social medias that you'd like to promote? Are you
No, I mean, I'm on Twitter, you've probably seen, but I'm on Twitter just to see. Actually, it's the fastest way sometimes you get the news is Twitter. I like just to see what people say. I don't post much. I used to be more active in social media. Facebook is like, I don't have any words. I mean, I don't even. I only go on Facebook on the doctor groups where I participate with other DPC doctors. If I have a question or somebody's got an issue or something, but I don't really partake much of social media anymore.
At least you did a lot of podcasts. Do you do podcasts very much anymore?
I like podcasts. Yeah, it's, and I've tried to do Instagram, and I'm not that good of a photographer, and I forget about it. So then all of a sudden, it's like 3 months, and I haven't put anything in there. I think I'm not in the generation of social media. Twitter I like just because it's so fast, And I'm a fan of Formula One, so I follow all the drivers, and I'm all into the drama of Formula One, and so that I like. And then I see, jokes. So there's this ophthalmologist that's very funny. He's got all these videos. So if you ever want to see those are very funny. I can't remember his handle, but he makes fun of everybody, fun of the doctors, the insurance companies, everybody. But yeah, I don't do much social media. Sorry.
Well, we'll definitely. I mean, we'll use you as we can be your social media platform. So,
There we go.
Oh, there you go.
so we'd love to have you back. We really appreciate you spending the time with us today. Always fun to chat, and thank you so much.
Yeah, thank you for doing what you do.
Yeah, thank you for having me. It was fun.
All right. Well, everybody, thanks for listening. This has been We Love the State. Actually, Dr. Amat, what's your website? So just in case you open up for new patients.
It's dpcwestmi.com.
Okay. All right. I'm going to put all that in the show notes. All right. Thank you so much for being here with us. I really appreciate it. This has been a fascinating episode. So I hope you have a great night.
Thank you. We'll talk to you soon.